We've been hearing a lot about supply chains. In fact, most of us, probably our entire experience with the term supply chains has come during this pandemic. And we're going to be talking tonight about the U.S. drug supply chain and our over-reliance on a certain country. We'll be talking to managing partner of PCS Advisors, Paul Seegert. He's a financial advisor. And the country is not Russia. It's not China. It's India, Paul Seegert. That surprises me.
Yeah, they are responsible for 40% in some recent years, 40% of all the approved generics by the FDA. And while most of us prior to the pandemic had, if we were asked, we would have said China was the source of most of the active ingredients in generic drugs. During the pandemic, a little-known 200-year-old organization, U.S. Pharmacopoeia, decided to take a massive undertaking and trace where we're getting all of these drugs from, and more specifically the active ingredients in these drugs. And it turned out that India is much bigger than China and really has the lion's share of this market, which has been a surprise to the industry and I think highlights some real threats that we could face.
Well, it highlights a stupidity of the part of this country. There's that old quote that may be apocryphal attributed to Lenin, that when it comes time to hang all the capitalists, they shall be found bidding on the rope. We have turned ourselves into a pack of prostitutes. Hey, we can save a penny, a pill or something on drugs. All we have to do is put our fate in the hands of other countries. Now, to put our fate in the hands, of course, of a country like China, a purely predatory country, is the rankest of stupidity. India, not quite so bad, but there are certain things that we need to have the capability to make ourselves, period. And if it costs a little more, well, then it costs a little more. I mean, the level of stupidity that is in existence in this country at times just drives me crazy. I find it incredibly hard to believe that we can be this stupid. The certain thing, okay, if you're talking about wheelbarrows or brooms or something, whatever. It doesn't matter where you get that stuff. If there's a shortage of wheelbarrows, I'm sure we'll get by. If there's a shortage of a critical drug, like, say, for diabetics, we may not get by. And so the question here is a question that, quite frankly, eludes me. How can we be so short-sighted? Do we really think that we're all just one big world and that economic advantage is the only factor in the world? There are no people out there who would try to do us harm? Are we that stupid?
Well, if we leave it purely in the hands of those looking to get that extra penny in profit per pill, we are that stupid. And I'll define it even a little more for you. I was doing some digging and research before our time together tonight, and a couple of numbers jumped out at me. Check this out. 83 of the top 100 drugs that are consumed by Americans have no active ingredient production in the United States. We can't just turn it on and start producing those pills for the people that need them, many of which are life-saving therapies for chronic conditions like what you've mentioned, diabetes and other things, heart disease, the generics for Lipitor, these kind of things. 83 out of 100. If someone decided, and it doesn't have to be that it's a country that is your political enemy. It could be a friendly country. I would say India is generally friendly to the United States.
Yeah.
However, when it comes down to hoarding supplies for their own population or preserving supplies for their own population, were there to be a shortage, or shipping them overseas, what are they going to do? You have to expect that they're going to protect their own. In fact, they did that during COVID. They stopped shipping. They banned shipping of certain antibiotics and even acetaminophen, which is, the active ingredient in Tylenol. So there is precedent for it, and it should cause concern.
It certainly should. I mean, again, do you see us waking up finally to this simple truth that the world is not just one giant happy place, all holding hands and singing Kumbaya? Have we finally awakened to that notion?
Well, I certainly hope so. We've got, and I think we might have help that's kind of irreverent to say, but with what's going on in the world with Russia and what it's done to energy prices in the whole COVID experience, I think those two things together may be the wake-up call that we need when you're looking at the fact that air transportation costs are up 227%, ocean transportation costs are up 193% since COVID. You're now having these folks that maybe don't really care about anything except an extra penny or 2 or 5 or 10 per dose, saying, okay, it might make sense economically to bring this back stateside.
Well, again, I would have to interject at that point. Yes, I'm glad to hear that it makes sense economically. It makes sense otherwise. in more important ways. And again, I would, whatever it takes to slap some sense into these idiots. It is not just about economics. What does it take? What does it take to get into these people's heads? Are they unaware? Do they not read any paper except the Wall Street Journal? Do they not read any page except that with the business news and the stock reports? I mean, are they unaware of what's on the front page?
And you know what? It even goes beyond the dollars and cents of it, but it gets to a quality issue too. Even if there weren't the potential for disruptions in the supply chain, which could be very catastrophic, because we're not all one big happy family, as you pointed out, you also have quality issues. If you are taking a generic, there's so many people in this country that are on statins, Lipitor and the generics of that, atorvastatin as an example. And if you get one of those generics that's manufactured in India, and there's 2 million people right as we speak that are taking a statin that was manufactured in India, a generic from India, they have a 60% higher likelihood of having adverse events from that drug because of the quality issues and the lack of oversight that occurs in that marketplace as compared to the kinds of controls we would have here or in Europe or in Canada. So it's not only are they it's maybe even worse than what we've described so far. Certainly they're going for profits, but they're even doing it at the expense of quality that has real measurable impacts in terms of adverse effects on our population.
There are two things that we definitely need to do here. One, we need to get the whores out of our decision-making process. And number two, there have to be moves made to see to it that the MBA factories, the Whartons at Penn, the Sloans at MIT, start teaching things about, ethics. It's more than just about how damn much money you make. I mean, we are allowing ourselves to be led by a pack of self-appointed elites who know the price of everything and the value of nothing. We're going to come back and talk some more with our guest, Paul Seegert, managing partner at PCS Advisors, and to look at this particular issue. It's one I hadn't heard before, that the U.S. drug supply chain is overly reliant on India, and that in a lot of different ways we're overly reliant on the rest of the world about important stuff that we need. Back in a moment. Welcome back to the Jim Bohannon Show at 1-866-50-JIMBO, 1-866-505-4626, with financial advisor Paul Seegert, managing partner of PCS Advisors. Who is PCS Advisors, for those who don't know, and I guess many don't?
Well, we work primarily on behalf of employers, getting the waste out of their health care spend in the way that they provide benefits to their employees for the most part. We've talked about it a lot on your show, that healthcare is full of waste, and it about doubles the cost of what it should be. And we work every day to kind of root that out.
Yeah. All right. Now then, who was it who discovered this thing? It sounded like some ad hoc group that just was kind of thrown together. I mean, like there's no one in an official position in government whose job it is to see where we are vulnerable because of the fact that we outsource. I mean, who was it who actually discovered this?
Well, it's a 200-year-old nonprofit that now houses this data that is far superior to anything our own FDA has.
So this is not part of government. It was somebody from the outside who just happens to do this.
They took it upon themselves and said, we are going to meticulously map the supply chain of medications that Americans take. and this was before not done. U.S. pharmacopoeia is pharmacopoeia, I think, however you say it.
Sure.
But 200 years they've been in existence, and the industry relies on them. They have the samples and quality. They're involved in the quality process of active ingredients and so on. But this is a new thing that they did, and now I think it'll become a very significant and important part of their business, where they can sell this a service to big buyers. And like whether, let's call it a hospital or policymakers, to say, here, look, based on our reliance and what's going on in the world, we may face a shortage in this area.
Oh, has this attracted the attention of our government? Did somebody actually raise their eyebrows and say, gee, that's interesting?
It has, and there is some legislation that's being worked on. Now we know how efficient that can be or not be, but the idea, there is some talk at least, and some movement in the direction of creating some incentives that can encourage production in our own continent, between Canada, U.S., and Mexico.
Government expands in every direction, for Pete's sake. We keep track of which statues offend some people. And nobody has found it necessary at the governmental level to maybe keep track of something that actually matters. I find that astounding.
They weren't keeping a close eye on this. Yeah, they were not keeping a close eye on this. And now the FDA would do well to simply call these folks and ask them for some input, and so would our Congress, frankly.
Well, I mean, yeah, but we should also, that'd be step number one. Step number two would be to stop depending on some outside group that just happened to look into it. Get off your lazy duffs and start doing something about things that matter to Americans. This is stuff that matters. They shouldn't have had to turn to some outside nonprofit who may or may not have decided to do this. There should be a portion of the government dedicated to just this kind of thing. I mean, we have portions of the government dedicated to total nonsense, for Pete's sake. But this we can't get upset about. It's remarkable to me, honestly, Paul. Just remarkable. We don't have our guest. Well, we'll get him back, of course, as we always do. 1-866-50-JIMBO is our number. 1-866-505-4626. And this is absolutely remarkable that the vast majority of drugs that Americans need are, in fact, not coming from this country, and we don't have the capability of making them in this country. And it took a nonprofit private organization to actually dig around and discover that this was happening. And I find that just amazing. That's one thing about government. Government has a tendency to go anywhere and everywhere. Why? Are we needed there? Well, it doesn't really matter. We'll just pretend that they're needed there. They go there because they build turf. Well, okay, I understand that bureaucrats build turf. It's often a rather expensive and quite frankly egregious activity in which we find government extension into areas that really are none of their business to be a bad trend. This is one case where the natural turf building instinct would have been helpful, and we do have Paul Seegert back now. I find it amazing that some bureaucrat at FDA hadn't said, gosh, here's something that we could actually look into that amounts to something. I'm surprised that nobody over there said, here's what we need to be doing. Nobody thought of it.
It's shocking. And we do need government. I know it frustrates us sometimes when we feel like they're in our business too much, but we need government to. We
need government in its appropriate place. Yeah,
things in place. Yeah, I mean, look at our drugs. We've talked about the overall drug market before, and I thought about this conversation we were going to have today. What do we need to do? What should we do? We need domestic production. And when people cry about cost, for one thing, I agree with your point. Sometimes you need to pay more, but on the other hand, when you look at our system, and you have 30, 40, 50, 60% of the cost of prescriptions that we pay is really just flat out waste. Why don't we get some common sense government involvement there to allow free market forces to work and eliminate some of that waste, which would more than cover the cost of bringing this back on shore?
And there's something else to keep in mind as well, and that is, of course, that most of the other friendly nations of the world, Western Europe and the like, have caps on what drug companies can charge in their countries. And so the drug companies, and it is expensive to develop a new drug. And, of course, the batting average, I'm not sure what the batting average for new drugs is, but sometimes they don't work as well as we'd thought. Sometimes they have dangerous side effects. And so not all of them can get to market. Okay, we accept that. But the drug companies say, all right, Europe, fine. You've got a limit on how much we can charge. Okay, we'll make it up on the Americans because they're stupid. And we ought to have a law in this country, and a very simple law. I could fit on one page, and it would simply say, basically, that drug manufacturers may not charge more here than they charge in other countries. And that would force the drug companies to raise the price elsewhere. And the hell with the Europeans, if they want some new magic drug that comes along that can cure some really bad disease, they'd have to change the cap on their drug costs, and they'd actually have to start paying their own freight instead of leeching off of us like the parasites that they are. Why don't we pass such a law? I mean, any member of Congress who is instrumental in passing such a law would get a 10% bump in the percentage of the voters who like them.
If not more, and it's only 1 in 5,000 drugs that they develop that makes it to market, and we do pay the lion's share. There's no doubt we're funding the R&D for the most part for the world, and that is part of the problem. And you know what?
In the prior
administration, Yeah, they were making moves toward it as an executive order, and then it got tabled when the new administration came in. And that's not a political statement; it's simply a statement of fact.
Why would it get put aside? I mean, I know that the drug industry has got a lot of money to throw around, but money means nothing to a politician. Money means nothing to a politician unless it can be helped to get them reelected. This is the case where you take that money from the drug company, and you're hurting your chances of reelection.
I know, it's incredible. And, the other unspoken part of the problem, or little known part of the problem that we face, is that, yes, we're paying a higher price, but who's driving that waste? It's not just the drug manufacturers. In fact, in many cases, year over year, our drug manufacturers make less on the drug year over year, and the middle players, the pharmacy benefit managers and the like, make more and more.
Who are these? Who are these middle players?
Yeah, these pharmacy benefit managers basically control the formularies for the drug plans. So they get to say, yes, the drug can be on the list. Here's what the copay is. And it only gets on the list if you pay me this many dollars. I mean, it's really that simple.
We are coming up on a break that doesn't move, but I want to definitely hear the rest of that, in which apparently fraud is being bribed into the system. Welcome back to the Jim Bohannon Show at 1-866-50-JIMBO, 1-866-505-4626. I'm grateful that somebody stumbled across this. I am. But the United States has a long history of lucking its way into survival, of making the wrong decisions for the wrong reasons, and then events turn against us and things look dark, and then all of a sudden our luck changes, and we pull it out of the fire. Things move a lot faster in the 21st century, and I really fear for this country. I'm not sure that old habit of depending on luck is going to necessarily hold out. And this is, Paul Seegert, as we take some calls here, and we have a number of people who want to talk to you, this could be the tip of the iceberg. It's a national attitude. It's a national craziness that we can just immerse ourselves in unimportant things, in bridges to nowhere, in post offices where there's no need for a post office, and ignore important stuff like this. I mean, just to pick one example, we have virtually nothing in the way of defense against a big asteroid hitting this planet, like the one did that 65 million years ago that killed the dinosaurs off. We might want to think about that as maybe being a little more important than some of this private crap that members of Congress think are so vital to their individual constituents. It's something that has the potential to be deadly, absolutely fatal to this country if we don't change our ways and develop some sense of long-range importance and substance to the way we make decisions in this country. Just before we go to the calls, are you aware of anything besides the drug supply chain where the same attitude is lurking, just waiting to stick a dagger in our backs?
Well, the drug supply chain is critical, and then our own players within our own country. We're sourcing these active ingredients overseas. That's a major problem. And then we're allowing these middle players to absolutely rape and pillage our economy, and I don't think I'm overstating that. They are, I think, the single biggest threat to our economy is the lack of transparency we have in the way that we pay for health care.
Now, these people who determine these costs of what is it that this group does?
Pharmacy benefit managers.
Pharmacy benefit managers, and they determine what?
That's right. They lord over the access to the drugs. If you're an average American with a health plan, they decide if it can be on the list of drugs you can access through your plan.
Who appoints these people?
Oh, well, boy, there's a lot of history there. In order to get Medicare passed, part of the agreement that had to be made was Medicare would not be able to negotiate itself. It would have an intermediary that would do it for them. And that kind of was the advent of this whole problem. And now, especially in the last 12 years, since the Affordable Care Act kicked in, it's just gotten worse and worse. There's very little transparency. And these folks are able to determine if a drug can go on the list, if a generic version of it can go on the list. There may be a generic available, but they may not let it on the list.
Why not?
And
Why
they
not?
may charge
Why
30,
not?
40, 50, 60% because they can say. I mean, it's really...
They're not letting it on the list because it's not safe, or they're not letting it on the list because they don't want to?
Because they don't want to.
And something else, before
the
break intervened, I thought I heard you say this, and I just want to be clear. I don't want to put words in your mouth. Are these managers being essentially bribed to play favorites?
Well, yeah, I mean, that's how the system works. They get to say, if you want your drug on the list, I want a rebate it needs to be this much.
A rebate
And
to
those
whom? The
negotiations-
manager? To the company the manager
Yes, to
works
the manager
for?
that manages the list.
The manager?
To the company that manages the list of drugs.
We have institutionalized bribery making this decision?
Yeah, absolutely.
Who
Yeah,
thought this
absolutely.
was a good idea?
Well, I'll tell you what. The industry itself thought it was a
Well,
good
who cares
idea,
what
and
the
they got
industry
to make
wants?
their
I
own
don't
rules.
care what the industry wants. I care what this country wants. And Congress said, well, okay, you just go right ahead and do that. We are so
You know what?
subservient to the
Yes.
pharmaceutical industry.
Unfortunately, yes.
We are so subservient to the pharmaceutical industry that
Yes.
that we just simply sat back and said, well, okay.
Look at what's happening right now in the news with insulin. It's right now being discussed. It just got passed in the House, and this fair pricing of insulin bill that's coming out, and I'm not naming it correctly, but it's something along these lines, where the Congress gets to come out, have a good precedent, and say, hey, we're taking care of you Americans, you consumers. You're not going to have to pay more than $35 for insulin. But when you get down in the details of what they're doing, they're completely ignoring the real problem. They're saying your copay won't be more than $35, but all this waste and abuse and what you might say is fraud and that's going on, that's jacking up the price of these drugs, it can continue. They're
Well,
leaving that
there's
completely untouched.
There's the old story about the guy who couldn't get a mule to pull his wagon, and an old farmer came by and looked at the situation and said, well, I can see the problem here. The farmer reached over and he picked up a nearby 2x4, and he smacked the mule right between the eyes with the 2x4 as hard as he could, and the mule collapsed onto its knees and finally got up, shaken. And the owner of the mule said, what'd you do that for? And the farmer says, first you have to get their attention. The pharmaceutical industry needs a 2x4. Here's Cliff in Fairton, New Jersey. Good evening, Cliff.
Good evening, Jim. Thank you for taking my call. And I want to thank you, Mr. Seegert, for bringing this to attention. The first thing I want to say, I want to make this real brief because I know Jim will cut me off in a minute. This is nothing new. This has been going on for a while. It's been 21 years in the military, and I thank you for your service too, Jim. I know you spent some time in the military. And I was in the healthcare professions all of those years. And this is nothing new. There were articles about this 4 or 5 years ago. There was a documentary on 60 Minutes about them not being allowed to investigate or inspect the facilities that these drugs are being made at. And so what I want you to speak to is the efficacy of these drugs that are made over there that we have no control over inspecting. Secondly, this is happening in the VA, Jim. In the gym, they control those formularies in the VA. Those drugs, they're taking the generics and using them exclusively, and they tell you can't receive this type of drug because that's not on the formulary.
All right, let's let our guests address those issues. First, the issue of quality from all this outsourcing, Paul.
Well, it's a great question, and I'm going to give you a good answer, I think. If you were walking around New Jersey where you are today, and you were to say, how many FDA inspectors do we have here, you would find dozens. If you were to go to the entire country of India, you'd be lucky to find a dozen. That's a challenge, and you can be sure that's going to lead to quality issues. That's why we have
and we depend
higher
on these
adverse
people.
events.
We depend on these people for drugs, and there's no deal set up that since we're taking your drugs, that we get to do some inspecting. Nothing like that.
Well, there is, but here's the FDA's excuse, you might call it, or just their explanation as to why they don't do a better job in this area. The problem is, and this is word for word. Problem is, the FDA can't find people who want to live in India. So
well, then pay them more. If there's a problem of desire, then pay them more.
Amen. Amen.
I mean, we have people that live virtually anywhere in the world. You pay them enough money, they'll go there.
That's right. And so now they shut their office in Mumbai in 2016 because they couldn't find people to work in it. Apparently.
And paying people more wasn't sufficient inducement.
I'm sure they didn't. They clearly didn't pay enough. They didn't pay.
Well, then they need to pay more. If we're depending on these places for drugs that keep people alive, then I guess it's kind of important. So maybe we need to raise the pay some more. And the second point that was brought up by Cliff is this affecting the Veterans Administration medical system?
Well, absolutely it is, because they too rely on one of these pharmacy benefit managers to manage their formulary, and that pharmacy benefit manager gets to pick the drugs, and they pick the drugs based on. At least in part, based on the compensation that they receive for putting that drug on the list.
This country is a piece of work. We'll be back in a moment. things that we do in this country are amazing. We're talking to Paul Seegert of PCS Advisors, financial advisor. We're looking at the supply chain and other problems that we have regarding pharmaceuticals. Here's Jim in Marysville, Washington.
Hi, Jim. How are you?
Well, thank you. But then again, I'm not on a lot of drugs right at the moment either, so go ahead.
I have a question for your guest. I have felt for some time that the drug companies make treatments rather than cures to maximize profits. Does he feel that way too?
Well, that's not to say that everything that comes out of the pharmaceutical industry is automatically there to hurt the American public and make them richer. For one thing, if it hurts the American public over time, it'll make them poorer. The only way they make more money is if most of their products do work most of the time. Just so we're clear and don't set a new record for the gross national cynicism here, Paul Seegert.
Yeah, I would agree with that. But I would also say that what we do see when people ask me how can we fix this whole problem, one of the things that I talk about is the orphan drug rules, where there's some rules that were set up to incentivize drug companies to create drugs for diseases that maybe only affect a couple of 100,000 people. They're not really widespread, but they're important to that subgroup. And so we created incentives. And they have a lot less controls over what they're doing, longer exclusivity, tax breaks, etc. And what that's resulted in is drugs that, there's an example, hypophosphatasia is a rare condition, mineralization in the bones and teeth that it affects. There's only 500 or 600 known cases in the U.S. Still, a drug company made a drug for that, and they're charging, it can be $2.3 million a year to have you on that drug. So they're definitely profit motivated. They're going to target in on things. If we create the right rules and the right incentives, they're going to exploit those. Now, that could be seen as a negative or positive. I think in this situation that we're talking about today, where we would like to see, I think a lot of rational Americans would like to see that we have the capacity to produce the drugs we need here. Let's create those incentives to do that, and they'll respond.
Well, are they actively fighting that if they have such a sway over our Congress? Are the pharmaceutical executives actively fighting that very notion?
I don't think that there's fighting against that. A lot of the industry executives are focused more so on the high-dollar drugs, the brand, specialty, et cetera. And what we're getting sourcing from countries like India tends to be the generic drugs, which are 90% of the drugs we take. So it affects the population quite a bit.
Okay. Anne in Indianapolis, good evening.
May I make a couple of comments to reinforce what you're talking about?
Of course.
I worked for the largest insurance broker in the world, not company, broker.
Okay.
I finally left that company because I saw that the American medical industry is going to bankrupt this country. Now, American medical industry owns Washington, lock, stock, and barrel. And
well, that's a bit of exaggeration, but they have undue influence, Anne, I'll give you that.
No.
No, they do not own Washington, but they have undue influence. But go ahead.
They own, it's money and greed, pure and simple. I used to hang out with the great and the good in Indianapolis. I can tell you how it works. But $500,000 for a chemical for early treatment of bladder cancer. That's the beginning retail price. And it's just it's pure greed. Now, we get good treatment. I get good treatment.
What was the $500,000 for? That sounds like a low price for a major drug. What was that money being used to do, Anne?
Treat early stage bladder cancer.
And the $500,000 was what, the cost per patient?
Yes.
Over what period of time? Over what period of time, Anne?
1 hour treatments over 6 weeks.
How often was this treatment given?
Once a week.
Once a week, so $500,000 a week for 6 weeks. That's $3 million over a month and a half. That was how much this drug would cost. Okay, go ahead.
But you realize that none of the regular hospitals in Indianapolis will treat early stage bladder cancer.
And why would that be?
I'll tell you.
Well, briefly, we're coming up on a break. We're overdue for a break.
there are no back-end charges that the medical industry can make. The cost is up front. They can't charge on the back end.
All right, we're getting into an area here that's going to require some explanation. Please stay on the line. We'll pause briefly and be back in just a moment. 1-866-50-JIMBO, 1-866-505-4626. Our guest is Paul Seegert, a managing partner at PCS Advisors, online at their name, pcsadvisors.com. We will get to your call if you're online, so just stay online. Because our guest, Paul Seegert, has graciously agreed to stay into the next hour. Now, Ann in Indianapolis was bringing up a number of things which sound like they were going to take a little time, so we paused. Then please continue, Ann.
Thank you. I'm talking about the way the world works on the street, not the theory, not the... As I said, I used to hang out with the great and the good in Indianapolis at the State House and at the City County Building. I know...
Now, by the great and the good, you mean what? The powerful politicians?
Yes.
Okay, well, just so long as we got the great and the good defined. Okay, you used to hang around with powerful policy people. Okay, go ahead.
And I can tell you exactly how it works. It has to do with money and only money. Mm-hmm. And what I saw, why do you think Washington will not let us see retail prices, beginning prices, before all the entities bargain? Even though we pay the bill, I pay the premium, I pay taxes for Medicaid and Medicare, I pay the bill. Washington, the medical industry will not let us see the prices. I saw them because of where I worked. Because we paid the bills.
All right, well, now, in the case of your $3 million for this bladder cancer drug over 6 weeks, I mean, we are aware that some of these modern miracle drugs are very expensive. Okay. Are you saying that is not the actual price?
I'm saying that no hospital except the VA in Indianapolis will treat early bladder cancer because they have to pay that cost up front, and they can't make any charges afterwards because it works.
It works, and it works for whom? In what way?
The people who have early stage bladder cancer.
Oh, okay. All right. Our guest has about 30 seconds to respond. Paul Seegert.
Well, unfortunately, there is truth in what you say, that treatments that don't provide the opportunity to get some of the rebates and other unknown profits that are attached to them get deprioritized.
And the fact that a drug works is a reason not to use it?
Well, not so much the fact that it works or not. I wouldn't necessarily say that that's the case, but if it doesn't include some of the other sources of revenue that they want to see, it will get deprioritized. And we can talk. All
right, we will pause briefly and we'll take more phone calls. Stay with us, 1-866-50-JIMBO. Paul Seegert, managing partner at PCSadvisors.com. I'm Jim Bohannon, and this is Westwood One. We've been talking with Paul Seegert, a financial advisor, managing partner of PCSadvisors.com, and a healthcare consultant, and we've been learning the litany of horror stories that exist behind American policy as regards drug availability and cost in this country. And let's take a call from Rick in St. Cloud, Minnesota. Good evening, Rick. Oh, well, Rick, feel free to call back. Kimberly in Kalispell, Montana. Good evening, Kimberly.
Hi, thank you. I specifically want to talk about insulin. I had a mother and a sister on insulin, right? And it was covered. Are you there?
Yes, we hear. You have a mother and sister.
Sorry. Yeah,
go ahead.
It's my delay.
It's what?
It's my delay. Anyway.
Okay.
So here we are. Really stupid thing. We had a diabetic cat diagnosed by our vet. So when we first had to buy a 10 milliliter, is that correct, Paul?
Well, 10 milliliters refers to roughly a tenth of a quart. Okay, it's a measurement of volume.
Very small amount of insulin.
Okay, I don't know how much insulin that is, but it's as I said, about a tenth of a quart. So anyway,
something like that.
In the neighborhood of a cup. Okay, go ahead.
Something like that. So it costs $100 to keep the stupid cat alive. and it went up to $200 or $300. So we went through Canada Pharmacy, to buy the insulin that had gone up to $300 in the U.S. And this is for a stupid cap. Can you imagine what it costs for people who are insulin dependent?
Well, I'm sure our guests can do more than imagine. First of all, I would note that that's one lucky cat, but I'll defer to Paul Seegert.
Well, what we're trying to do is limit the cost of insulin to a copay of $35 here, and they're paying $35 there. So, and we're allowing the middle players in our system and others who, frankly, are just piling on, in my opinion, to boost the cost for a box of Humalog, the most commonly prescribed insulin in this country by Eli Lilly, to $550. So the plan pays $550, and we have Congress acting as though they're doing something big for our consumers here by limiting their copay to $35, which will simply push more of the $550 cost onto the insurance plan that those same very people have, and at next renewal, they'll increase the premiums to accommodate it. It's a real shame, the shell game that they're playing with, talking about a copay as if it's cost.
Now, in this particular case, we're talking about a widespread disease. I think it would be safe to say that there is an epidemic of diabetes in this country, Paul. Would you agree?
There is absolutely an epidemic, yes.
And you're saying that this is yet another area in which we're not handling the situation well.
We're handling it horribly. The fact that we allow a rebate to represent 60%, and rebate, you can just put the word waste in there. The fact that we're allowing 60% of the cost that our system bears for insulin to be waste is unacceptable. That is ridiculous. And in fact, Eli Lilly makes Humalog, the most commonly prescribed insulin, and a box is about $550. They make their own generic that is the very same drug. It's just their own generic. And it often just isn't put on the drug list that you can get through your drug plan because these pharmacy benefit managers won't put it on because it doesn't include their rebate, their fee.
Are these people answerable to nobody? Are they answerable not to their own bosses at their company, not answerable to the U.S. government, not answerable to God? I mean, who are these people?
Well, you know what? There is I depress people a lot, and I don't mean to. There is optimism to be had, and it's not because of what the folks in government are doing. They're pretending they're doing something by controlling the copay, in this instance of insulin. But it's really the hope that I see and the optimism that I see is that employers who run health plans for their employees are waking up to the waste that's going on and getting with consultants who will work with them to partner with vendors that will not engage in these practices. And I really truly believe the American employer will fix the way that all of America pays for health care, and they're already doing it. One employer.
Are they being allowed to do it, assuming they have the motivation to do it?
Yes, they are. They can, and they will. They can't print more money to pay for something that's unaffordable. They have to make the money they have work, and they are doing it. And I'm proud to say that, excited to say that. And it is a movement that's catching momentum. So there is reason for optimism. I wish it would happen more quickly, and that's what we work on every day. But
1-866-50-JIMBO is our number. 1-866-505-4626 with Paul Seegert, managing partner at PCSadvisors.com. Do you have any more horror stories to drop on us? Because, I mean, these are things we need to know. In a free society, only an informed public can make good public policy take place. So we need to know this stuff. So please continue.
Well, I'll tell you one other thing that to me is extremely unacceptable and shocking in the way that our system works. And Mark Cuban is doing something that I think that could be helpful and disruptive in this area. And that is, if you are a pharmacy, you have a lot of good pharmacists out there who really care for their customers. But if you're a pharmacy and you take insurance in payment for the drugs that people come to get at your pharmacy, you're not allowed to determine your own fair cash price for that drug. So that not only do we have these middle players inflating the cost of the drug, we then have them dictating to the pharmacist what he's allowed to sell it, or she is allowed to sell it to an American consumer for it. So they don't use the insurance.
Yeah, the market forces are not
inflate it
allowed.
wildly.
Market forces
Exactly.
are not allowed to be at play here. Is that what I'm hearing?
Exactly right. That's right.
Is there a marketplace? In some circumstances in this country, we've discovered that the market forces of supply and demand don't operate because we don't have a competitive system going. We have a few big players, and that's about it. Is that a factor here? Do we have, in other words, left to their own devices for the pharmacists, is there enough of a marketplace for them to actually bring about change?
Well, there have been some who have tried. They're so small, though, that they really get drowned out by the big players that are controlling the model that's not efficient by design. Yet, there is, I think, some reason for optimism right now. Mark Cuban's Cost Plus Drug Company, the thing that he did in the formation of this company that is so revolutionary, so simple on the one hand, but so revolutionary on the other, is that he said, we're not going to take insurance. And that gave him the freedom to be able to say, we're going to buy a drug from the manufacturer and add 15% markup and sell it to the consumer. That, believe it or not, is revolutionary because he cut out those middle players that are adding all the waste. He's not going to wildly inflate the cost. He's going to make what, for this industry, is a small margin, plus a transaction fee, and deliver the drug to the consumer. So I think it has the chance to be quite disruptive.
Very interesting. I must say, we have Rick in St. Cloud, Minnesota, has called back in at 1-866-50-JIMBO. Go ahead, Rick.
Yes, thank you for bringing this important topic to the air. I have a question about active ingredients. When they make these drugs, are those active ingredients something concocted in a test tube, or is this something coming from plants or minerals?
Well, were you asking whether they're, quote, natural, unquote? I mean, I will pose that to our guest. I would note that I don't put a lot of stock in, quote, what is natural or not. I mean, there's nothing in the world more natural than crippled kids from polio. Polio vaccine is very unnatural, so I don't know that it necessarily matters. I mean, we're all made out of chemicals, number one. The idea that there are natural things and then there are chemicals. No, everything is made out of chemicals, just so we are clear on that. But go ahead, Paul Seegert.
Well, I think the active ingredient could be any of these things. It's just whatever works. Whatever can make it effective against the condition that you're trying to treat. So sometimes they're synthetic, sometimes they're from a natural source. The key is... But
they're all chemicals, just so we understand that. I mean, if people never took chemistry, everything is made out of chemicals. Okay, go ahead.
That's right. And the real question here is, can we access it when we need it? Do we have any control over that? Or are we leaving that to some other government, some other country, and taking that risk, which we are currently, unfortunately?
All right, 1-866-50-JIMBO, 1-866-505-4626. More calls to come here as we talk with Paul Seegert, who's agreed to stay over, and he's a managing partner at PCSadvisors.com. We've got a few things we need to fix in this country. We'll be back in a moment. Welcome back to the Jim Bohannon Show at 1-866-50-JIMBO, 1-866-505-4626, as we look at some of the problems we face in this country with drugs, availability, prices, and what have you. Ken in Sheridan, Wyoming. Good evening, Ken.
Hello.
Yes, you're on the radio. Go right ahead.
Okay, I just wanted to comment on a couple callers ago about bladder cancer and $500,000 of treatment.
Yeah, the lady from, I forget where now, but yes, go ahead.
Well, I've had it twice, and they use a drug that is in layman's terms, just live tuberculosis through a catheter into your bladder, and it sends all the troops down there and takes care of it and takes care of the cancer at the same time. And it costs me, virtually nothing, but it's a very effective treatment, and had I followed my doctor's instructions better and drank more water, I probably wouldn't have had the second dose.
Interesting. Okay, I guess there are different treatments, obviously, available. Go ahead, Paul Seegert, your response?
Well, I think we need more of that, where we're getting these treatments done, and fortunately for the whole world, they're getting access to them because we are funding it as Americans. And I think we should share it more globally and eliminate the waste, and we could even produce more of these kind of life-saving treatments.
All right, let's talk to Judy in. Good luck to you, Ken. Let's talk to Judy in Paducah, Kentucky now.
Hi, thank you for taking my call tonight. Very interesting topic. I have several chronic medical problems, and I had a friend that went on vacation to Mexico and went to Walmart in Mexico and brought me back well over $1,000 worth of medicine for less than $100. You did not need a prescription, and of course there were medications on every street corner bodega, including the hard narcotics, and you did not need a prescription. You just walk in, pay them, and off you go. I just felt a little bit more protected by the name of Walmart. Maybe, quality would be a little bit better.
Well, I mean, that's, of course, the big issue. I'd like Paul Seegert to address that. What Judy did, obviously the price savings are obvious. Can you put any more faith in the quality of those drugs from Mexico as you could put in the quality of the drugs that we're getting from India?
Well, I think if the drugs a lot of times a drug is manufactured in one place and then it gets shipped everywhere. Like there's drugs that are shipped or manufactured rather in Puerto Rico, and then they're shipped all over the world. Humalog, the insulin that is the most commonly taken, that's the case. And so if it's a drug that's in Mexico where it's being purchased, but it's manufactured in that one place where that drug is always manufactured, and it's a legitimate copy of that drug or a legitimate, that is the legitimate drug, then you've got a better value buying it there than you did here, unfortunately.
Is that worth it? I mean, you don't consider that a risky proposition that Judy has undertaken?
Oh, it could be very worth it. We have some cases where we actually a drug can be so wildly expensive here that it can make sense to put someone on a plane, send them to San Diego, give them a fun weekend, and have them walk across the border and fill a prescription once a quarter. And your health plan could save hundreds of thousands of dollars here in this country. That's crazy that makes sense.
That sounds like somebody making sense out of a crazy situation. So,
right, exactly right.
All right. Well, good luck to you, Judy. Gary in Franklin, Kentucky. Good evening, Gary.
Good evening, Jim Bo. Thanks for taking my call. Now, what I'm talking about is not pharmaceutical much, but I had a knee surgery done. I had to have an MRI done on it. I had insurance. Well, the MRI cost me $1,500. Well, when I go there and to get it rechecked after surgery, I tell them, I say, I have no insurance. I said, well, we need $1,500. Well, I say, I ain't got it, and I thank them. Well, 5 minutes later, they call me back. If I got $1,100, they will do that MRI. I told them, thank you, I appreciate it, but I don't have it. Well, they call me back. If I got $700. So sometimes if you tell people that you don't have insurance, you'll get the same treatment for $500, $700, $800 cheaper just because they want your business, and it keeps the insurance out of it. It sounds to me like Mitch McConnell and the Congress and people are doing the same thing that some of the presidents and them do with their foreign affairs money. They'll say that you will give you $50 million, but you give me $20 million back off the top of it in some other account where it can't be traceable. I mean, that's a whole lot of crooked stuff going on in medical. And
that sounds like Monty Hall and Let's Make a Deal with your health care, Paul Seegert.
Well, unfortunately, your experience is right on the money. You can have, if you go in and say, hey, I'm a cash payer, it's not uncommon you might get an 80 to 85% discount off of what they would charge someone with insurance. That's rather crazy when you think about it. We're going to inflate the cost that much because you choose to have insurance. It's wild. It's wild how our system works.
I thought responsible people got insurance.
Well, and for that privilege, they might pay 6 times what that same facility would take from a cash payer after their insurance discount.
No good deed goes unpunished. We do have a few more calls here. We'll be very brief if you can stay over one more segment, sure. Paul. All right. Sure. So we'll get to your calls here and learn some more about drug supplies, cost, and the like. Folks, there are, I'm sure, all kinds of answers here, but what we have now ain't working. That ought to be clear. Back in a moment. Welcome back to the Jim Bohannon Show at 1-866-50-JIMBO, 1-866-505-4626, as we talk about some of the problems we have in this country with getting pharmaceuticals, with paying for pharmaceuticals. It's a crazy quilt situation. And as I said, there ought to be, I'm sure there's not universal agreement on what to do, but there ought to be universal agreement that we have to do something. All right, Mario in Sebastian, Florida. Good evening.
Yes, Jimbo, you're a gentleman and a scholar. Mega Pharma has a real, it's the way they do business. You know, I usually have to go to big clinics because I have a lot of money. I'm a Navy veteran, and I've got all kinds of stuff from the Navy. Anyway, what they do, they get in these large places, and they got to have a captive audience. And they have to, these drug salesmen come into these places, and they give the doctor hundreds of samples. We have this new drug for depression and anxiety and disorder. And it's a serotonin uptake inhibitor. What's the upside? You know what will happen to you with serotonin uptake inhibitor? After 8 years, you're guaranteed going to have it.
All right, thoughts, Paul Seegert?
Well, unfortunately, there are incentives for doctors to prescribe certain drugs. I mean, there have been drugs like Aduhelm, which is a drug for Alzheimer's that wasn't shown in clinical trials necessarily to be conclusively effective, and yet each time it got prescribed, that doctor would get between $2,000 and $3,000, and so you can be sure it got prescribed. And there are issues like that, misaligned incentives, I call them, which is a nice way of saying we're paying people to do the wrong things sometimes, unfortunately.
Well, it certainly would so seem. 1-866-50-JIMBO, 1-866-505-4626. And one other thing I can bring up here, that's intellectual property. Now, of course, the United States has become, over the centuries, something of a leader in innovation because of intellectual property laws, patent protection of the right. You come up with a bright idea, will give you an advantage of exclusive use of that right. Now, you get a certain number of years. I think it's 17 years, I think. But the problem is that the clock starts on new drugs the minute that the patent is granted, whereas the FDA may take forever in its process of okaying the drug. So let's say you have 17 years of patent protection, but the FDA approval takes 9 years. That leaves you 8 years in which you can actually use your patent protection. Now, I'm not sure those numbers are still accurate, but the principle is that a factor in what we're talking about here?
I would say it is, certainly. And, I think we oftentimes vilify the drug manufacturers, and they're not the ones adding the waste. A lot of times it's the middle players that are adding the waste, the pharmacy benefit managers and others. And they get about 20 years, but as you pointed out, that's from the date of the patent filing, which is usually several years before a drug's approved. So they have to make that money back. And then when you look at the way that, and they only get 1 in 5,000 that they attempt all the way through.
That's worth repeating. Of the drugs they try to make, from the idea of let's try this until we get to it's on the market, 5,000 attempts are made, and one drug is going to make it actually to the drugstore.
That's right. I mean, these companies are doing great work. I don't want it to seem like I don't think they are. They are. And they're not. They make, oftentimes, even during their years of patent protection, they're making less each year on that drug because of the demands that get made from those players that control the formulary to have it on the list.
Do we need to rewrite the patent laws?
Each year. I think we certainly need some common sense rules around how this game gets played, because the folks that are who are taking all of the risk are not the ones that are adding the lion's share of the waste to our system.
Here's a call from
Terry. A lot of blame for that.
Here's a call from Terry in Dubuque, Iowa.
Well, good evening to both of you. I'm a former pharmaceutical sales rep, and I switched over and joined the other side being an employee benefits consultant. And I would like your guest to answer this question. In my mind, what I saw was the pharmacy benefit managers, the PBMs, is absolute work of the devil. They take money out of small pharmacies' pockets, out of the community pockets. They're now all vertically integrated with a large drugstore, and they bring no value. However, most people think everything's controlled by insurance companies, where many times insurance company is just the administrator of the plan. The plan is controlled by the employer. What does it take to get 535 members of Congress and Senate in the United States to understand the robbery that is going on by pharmacy benefit managers. It is absolutely theft.
Okay, we'll put Terry down as undecided. Paul?
I agree with Terry. It is theft. I mean, it's one of the biggest threats our economy faces. And I think people ask me all the time, when will it stop? When can we fix it? When will it end? And unfortunately, my answer is oftentimes as soon as lobbying is no longer effective. Unfortunately, they're going to keep trotting out onto the stage talking about limiting copays for insulin to $35 and not even scaring or even threatening the profits that these pharmacy benefit managers are making. We've got a lot of work to do there, and I don't look to Congress for an answer. I do look to people like you who are going to work with employers one at a time to get the problem solved today. I think if we can get more of these conversations going like we're having with Jim today with big audiences, maybe we have a chance.
Okay, Jim in Pittsburgh, good evening.
I want to just echo what Terry just said. I worked as a pharmaceutical salesman also for 27 years. I'm now a Medicare broker, and I help people get their drugs. And let me just say this. What you guys are saying about the PBMs, or what your caller said, is 100% true. And with Medicare, it's even worse, because what they do, they'll take an old drug, generic drug, and I call it the branded generic charade, and they'll put it as a tier 3, and they'll charge you $50-$60 for it. You can get it. I tell them, use GoodRx, you'll get it for a lot less. My whole point is, we're giving these drugs to other countries at 10 or 20 cents, 30 cents a dollar. We're financing the research and development. If we had the balls, this has been going on for probably 30, 40 years, if we made them pay what we pay, it would bring our costs down. And I want to hear what your guests have to say.
Yeah, go ahead, Paul.
It absolutely would. I think what you're describing is a free market where they have to decide what a drug costs, and everyone has to pay that price. And we don't, as you well know, we're nowhere near that today. They sell it at a very low price to many markets and then make their profits here. We account for 80 to 85% of global profits. That's ridiculous.
Well, it certainly would seem to be ridiculous. All right, 1-866-50-JIMBO, 1-866-505-4626. And here is Dorothy in North Myrtle Beach, South Carolina.
Oh, well, good evening, Jim. It's great to talk to you. I listen to you every night.
Thank you.
I wanted to know, thank you for being there. I was wanting to know if your guest, Paul, could put some insight on why this particular drug I take is very expensive. It's called a biologic. And you're not going to believe this. When I get my explanation of benefits, it is $43,800. I'm serious. I've had 3 EOBs. I'm on Medicare, and Medicare pays $12,000 of that $43,800, and I just don't know why. It's once every 3 months I get this shot for psoriasis, and I can't understand how an EOB, like I've been in a hospital stay or something, could be $43,800.
Well, to me, that's the big storm cloud on the horizon for our economy, really, not just healthcare, but our economy, is the fact that we have drugs, and it gets back to what some of these prior callers have said, where you're taking a drug here in America, and they're going to bill $43,000 a pop, and other people are going to take that same drug in one of our peer countries, and they're going to pay $3,000, $6,000. So we're shouldering too much of that cost. And the drug industry increases prices semi-annually in this country. Just in January, they increased them 6.6%. And your drug isn't unique. Believe it or not, there are lots of prescriptions like that out there. The most commonly prescribed specialty drug right now was $60,000 in June of last year, and then in January of this year it went to $64,200, and in July of this year it'll go up to $68,000 or $69,000. It's incredible what they're allowing, what we allow to happen in this economy, and how it funds the whole world.
Pass a law that says that drug companies cannot sell drugs here more expensively than they do elsewhere. It'll force them to raise prices on the parasites who are passing the cost on to American consumers. Paul Seegert, thank you. Great program. Much appreciate you being with us.
Thanks for having me.
Paul Seegert, he's managing partner at PCSadvisors.com.